Yes, whenever you guys are ready.
Okay. Thank you, everyone who's joined to our core insights tonight. My name is Mickey Reinhorn. I'm in private practice, but I have an academic affiliation with Newton Wellesley Hospital, part of the Mass General Brigham system. I'm going to introduce tonight's speakers and help moderate some of the questions. If you have any questions, please put them in the chat and we'll get them to our speakers. We're really going to talk about our use of opioids and our prescribing of opioids and how we can affect change. So our first speaker is Dr. Rayna Higgins. She's an assistant professor at the Medical College of Wisconsin. She's currently the associate program director of general surgery residency. And her clinical practices really focuses on laparoscopic robotic hernia surgery, foregut, and bariatrics. Our second speaker is going to be Arielle Perez. She has both an MD and an MPH. She is an assistant professor of surgery and a director of the University of North Carolina Health Hernia Center. She's also the assistant program director for general surgery residency at UNC Chapel Hill. Both of them are going to give us our PowerPoint talks, and then I've invited a couple other members of our task force, Tony Iacco, who's the assistant professor of surgery at the Oakland University William Beaumont in Royal Oak, Michigan, and Teresa Dews, who's an anesthesiologist with expertise in pain management. She's also the president of the Cleveland Clinic Euclid Hospital. And she has been at this from the very beginning and helped found our task force even a couple years before we started. And then Todd Harris will be joining us. He's in private practice in hernia surgery in Southern California. So with that, Rayna, go for it.
Hi, thanks so much for the introduction, Mickey, and thank you all for joining us today. So we're going to be talking about opioids and how we as a task force have used the ACHQC to combat the opioid epidemic. So just a little bit of a background, the opioid task force was created in April of 2019 formally. As Mickey mentioned, it was really a concept thought up even years before that. It is chaired by Dr. Mickey Reinhorn, who introduced all of us today. And really the focus is to have a very multidisciplinary task force. There's 16 members and specialties include surgery, anesthesia, as he mentioned, as well as primary care. So when we first met, we discussed our task force goals, which were really to identify ways to reduce prescribing and the consumption of opioids in hernia patients. And we wanted to look at that in three ways: that data evaluation, also focusing on surgeon education as well as patient education. And we felt that these three components were critical in order to achieve the goals that we wanted to achieve. So the first thing that we did as a task force was we created and implemented an optional data tool in the ACHQC. This included data on opioid prescribing, the use of multimodal pain management, patient opioid consumption, as well as risk factors for patient chronic use of opioids. So these are found in 3 steps in the ACHQC database: pre-op evaluation, 30-day follow-up, and patient-reported outcomes. So these are the locations in which our data tools have been found. So once we created that data tool, the next thing we did was we identified as a task force that we ourselves were overprescribing. And Dr. Perez did present this information at the QI Summit last year, but if you look at our task force alone, so here in blue, you have patient use, and in red, you have patient prescribed. And this is all inguinal hernia, so an N of about 443 from 2019. And as you can see, the patient use is heavily on the lower side, between the 0, 1 to 2, 3 to 4. However, the prescribed by surgeons is much, much greater on the higher side. So really 11 to 15, 16 to 30. So highlights from this data is we found that half of patients took no opioids at all, and I'll show you a little bit more of that data. In fact, 81% of patients took less than 10 tablets, but 55% of surgeons prescribed greater than 10 tablets. So very significant discrepancy here in patient use versus what was prescribed. And this was data that we identified as a task force. So in November 2019, we, as a task force, put together a pilot study that we implemented among our members, looking at a multimodal treatment of post-op pain. So focusing on Tylenol, ibuprofen, ice, and really making a concerted effort as a task force to prescribe ourselves 10 or less opioid tablets in all inguinal and umbilical hernia patients. And also focusing a lot on pre-op patient education, which is something that Arielle's going to talk about in a little bit after I present. So we took our initial data and we presented at the QI Summit in Denver in December of last year, pre-pandemic, when we could meet in person. And Arielle presented that data. So she polled surgeons at the summit, and what she found was that less than 50% of all surgeons at the summit prescribed less than 10 tablets for inguinal hernia repair. So you can see here, the vast majority prescribed over 10 tablets, and only about 44% prescribed less than 10 tablets. So we presented our data and we discussed the importance of pre-op education for patients as well as best practices. And we really emphasize that multimodal should be the first line for post-op pain, and opioids really should just be considered as a rescue. And we challenged everyone with the goal to prescribe 10 or less opioid tablets for routine open and MIS inguinal and umbilical hernia repairs as a place to start. So the surgeons attending the summit committed to this multimodal prescribing practice and entering their data into the opioid toolset that we instituted into the ACHQC. And as you can see here, nearly 90% or 89% of those surgeons polled at the summit committed to prescribing 10 or less opioid tablets for all inguinal and umbilical hernia repairs. So what does the data tell us? We have the data going into the summit in December of 2019, and what has happened since then after the summit, when we discussed with those surgeons and emphasized the importance of a multimodal regimen and really trying to set a goal of prescribing less opioids. So the data analyzed includes both prescribed by the physician as well as consumed by the patient. And we are comparing both the 2019 considered pre-summit and 2020 post-summit data. So in terms of the way we categorize the data, so we looked at low, which is considered less than 10 tablets and should really be our goal. And obviously one thing, and Mickey will kind of discuss this, but patients with 0 tablets prescribed were actually missing from the data set, and we'll get into that in a little bit. But essentially, low, moderate, and high is how you can think of the prescription categories. Low being the goal less than 10, moderate 10 to 14, and high being prescriptions greater than 15 tablets. So when you look at the 2019 data, as you can see here, the light green is the high, and this is all for inguinal hernia patients. So 30% prescribed high, 25% moderate, and 45% low. When you compare this to the 2020 data, what was really interesting is you saw a decrease in the amount of low prescriptions for inguinal hernia, but you see that there's much less high, and that's all kind of migrated into a greater incidence of moderate. An interesting thing, though, to consider is that there were significantly more number of surgeons entering data into the opioid database for 2020. So in 2019, our N was 446. If you compare that, it's almost 3 times as many in 2020 with almost 1,200. So 52 surgeons versus 80 surgeons. So that has to be something to be considered as well. So essentially what this data tells us in terms of prescribing for inguinal hernias is we really migrated away from high to more moderate prescribing, when really our goal is going to be more low, but we have shifted the curve from high to more moderate. Now, when you look at patient consumption in 2019, I mentioned this data before, but 81% of patients consume less than 10 tablets, and 19% consumed greater than 10. And interestingly, 50% of patients consumed 0 tablets. In 2020, this data was even more profound. 90% of patients consumed less than 10 tablets, 40% none at all, and only 10% consumed greater than 10 tablets. So again, the same data set in terms of an increased data entry from 2019 to 2020. And essentially this data shows us that patients are consuming significantly less than we are prescribing, which is similar to the data that I showed you earlier. So for umbilical hernia, we see a very similar trend that we saw for inguinal hernia. So as you can see here, in 2019, high prescribing was quite high, almost 50% of umbilical hernia patients were getting greater than 15 tablets, 25% low, and about 26% moderate. When you compare that to 2020, really a dramatic shift from high, from almost 50% to less than 20%, with a greater incidence in the moderate category and slightly less for the low. But again, quite a shift from high to moderate. So again, very similar to the inguinal hernia patients where we saw migration away from high to more moderate prescribing. And when you look at patient consumption, very similar to what we saw for the inguinal hernia patients, in 2019, 65% of patients who had an umbilical hernia consumed less than 10 tablets, 34% of those were 0. And 20% increase here in 2020, 85% of patients consume less than 10 tablets. So again, a very similar conclusion that patients are consuming significantly less than we are prescribing. So in conclusion, opioid data entry participation has been increasing quite significantly since it was launched in the ACHQC in 2019. As you can see, from 2019 to 2020, we have almost 3 times as many patients. We have shifted the curve from high to more moderate prescribing, and patients are consuming significantly less than we are prescribing, but our goal should be low or no, as Mickey will talk to you guys about prescribing. And really, the goal should be less than 10 tablets for all inguinal and umbilical hernia patients. So we have shifted from high to moderate, but we really want to continue to shift the curve to low. And we really, as a segue to what Arielle is going to talk about next, we really want to focus on pre-op patient education and multimodal pain regimen as our primary focus, with opioids being a rescue. And as you all have seen, and as Arielle put together these handouts that have been provided by the task force to really help facilitate that. Thank you so much.
Thanks, Rayna. That was great. I will sort of fill in the blanks on the data set, because I think what we'll find in March when we have the complete data is our changes will be even more pronounced in terms of shifting the curve. When we started this 4 years ago and developed the module, I didn't even imagine prescribing no opioids. And so when we built the data capture, there isn't even an option to say we didn't prescribe any opioids, just prescribed over-the-counter analgesics. And so we're making the change, but we're also able to capture that data by looking at how surgeons coded it. And so it's just taking a little extra time, and that data will hopefully be available at the summit in March, and we'll present that. But I think that's why we're seeing a smaller percentage of patients using no opioids than in 2019, because we've omitted all the surgeons who have migrated and all the patients who've migrated to no opioids. So that was great. I think I'll turn it over to Arielle to tell us how we do this. I'd love people to chime in with questions in the chat box if you have them, and we'll send them up to some of our presenters.
Let's see here. Make sure, can everybody see my slides okay? Perfect. Okay, well, thanks, Mickey, and great kind of information about our ACHQC data, Rana. So my name is Arielle Perez, and I'm going to be going over the opioid reduction strategies and best practices that our ACHQC opioid task force has adopted. I have no disclosures. So as Rana said, in 2019, Mickey really started the charge with our opioid task force committee, and much of the information from our committee can be found on the ACHQC website under the Patients tab with the Opioid Reduction Initiative. The strategies and best practices address patient pain management during the preoperative evaluation, all stages of the perioperative care, and during patient follow-up. During the preoperative evaluation, patients are asked to fill out the preoperative patient-reported outcomes form, and that is also collected in the ACHQC. In the ACHQC dashboard, under the resources section, you can find patient-reported outcomes, or PRO forms, for both preoperative and the postoperative period. These forms are able to identify baseline opioid use prior to surgery, as well as postoperative opioid use after surgery. This information is then collected both in the initial patient-reported outcomes area, as well as the preoperative evaluation in the QC, along with characteristics known to infer risk of opioid abuse, such as behavioral health issues and opioid or other substance abuse. Now, during the perioperative phase, it's encouraged that providers educate and set pain expectations with patients, provide the ACHQC opioid education handout along with the discharge instructions, educate, prescribe, and recommend first-line therapy to patients, and prescribe no more than 10 narcotic pills. One of the big things that we want is during all phases of care, we want to encourage surgeons to educate and set pain expectations. Healthcare providers, whether it's the surgeon, a nurse, or a resident, should discuss medications and management strategies with the patient and family members in clinic during the consultation, in the preoperative area before surgery, and in the PACU after surgery. As part of the education piece, there's also an opioid education trifold handout that can be printed out and provided to patients. It can be found online on the QC website under opioid reduction initiatives in the patient section, where you can download a brochure. As well, we want you to remind patients about pain management strategies, and there's recommendations that can be copied into discharge instructions or printed out for patients. This as well can be found online on the QC website under opioid reduction initiatives in the patient section, where you can download a note card that has all the information for the discharge instructions for pain management. As well, we want patients to be reminded that opioids are a rescue drug. A surgeon should recommend and prescribe first-line therapy to patients, which include Tylenol, ibuprofen, and ice packs. Now, there are multiple institutions which have provided recommended dosing and prescribing practices after hernia repair. And the Opioid Task Force, based on QC data, has recommended a prescription of no more than 10 tabs for patients for umbilical and inguinal hernia repairs. During patient follow-up, the patient should fill out the post-operative PRO forms, and surgeons should collect their opioid prescribing data in the ACHQC. But why is this follow-up necessary? Really, it's so we know if we're doing the right thing. And also, as Rana said, can we get rid of opioids altogether and maybe go down to prescribing no opioids? Patient-reported outcomes can be entered by the surgeon or other staff members under the patient-reported outcomes area. There are specific collections of how many tablets were actually taken by the patient, and this is helpful for our post-operative evaluation of patients. Surgeon prescribing practices are also tracked under the 30-day follow-up area and under the post-discharge pain management area. Opioid specifics, as well as other first-line multimodal therapy, is collected in this area. So it is the hope that by utilizing these strategies and the best practices that we described during the preoperative evaluation, by obtaining preoperative PROs and collecting data in the ACHQC, during all phases of perioperative care, by discussing pain expectations and medication before and after surgery, by providing the opioid education handout and discharge instructions, by educating and prescribing first-line multimodal therapy, and by prescribing no more than 10 narcotic pills, as well as during follow-up, by obtaining post-operative PROs and collecting the data in the ACHQC, and by tracking surgeon prescribing practices, as well as collecting that data in the ACHQC. The hope is that we can reduce patient opioid consumption and yet still control patients' pain. It is the charge of every healthcare provider that we can and we must be the change. And for the Opioid Task Force, this is what we want to do. Just with our recommendations, with our best practices and our strategies, we hope that we can reduce opioid use with patients.
Arielle, that was great. I think Arielle spent a lot of time creating these handouts for patients, and they are available on the site. I will say that they're both for patients and surgeons, and I have found them helpful. And I know that they really sort of a very cookbook and how to really talk to patients about taking Tylenol and ibuprofen as a first line approach, and ice, and only using opioids as a rescue. And it's been a great template of how to speak to patients. There were a couple of questions from the chat, and I'm going to direct the first one to Tony. Came from Mike Rosen that we've been moving the dial. It's clearly we've moved the dial a little bit, but you've been pretty vocal in our committee about moving faster. What do you think the barriers have been, and what do you think it's going to take for us to move the dial faster?
Well, first of all, thank you guys. Those are nice presentations. This is difficult because it's frustrating to go through all this opioid data and present it to a group of surgeons efficiently and not in too much detail. It's very clear looking at this data that we overprescribe, that those of us that have seen this data, even in our own committee, continue to overprescribe and have a hard time changing. We sit in this committee and we talk about anecdotally what we're all doing, and we're all doing something a little different. We've all seen the same data, and yet, even this very week, I'm guilty of having residents change my orders, or having a PA change the orders and increase the dose. And so I think Mike asked the question about moving this dial slowly, but moving it a little bit. I think what we struggle with as a committee is presenting this data, like we had mentioned last week, in a way to surgeons that can get them to change. And I don't have the answer to how to do that, and I'm not sure our committee has the answer on how to do that yet. It'd be nice one email to change a surgeon's mind, but that's not enough. One presentation isn't enough. One paper people won't read. Talking to your partner in the hallway, that might be the best way. I don't know. But I am glad that we have made some change over the past year. We have a long way to go.
Well, I think you're right. I think that's been our biggest challenge is how do we affect change more quickly, and how do we get to a broader audience? I think one really nice aspect of this is that in a year, we've tripled the number of surgeons and patients that are reporting data, and we shifted the curve a little bit. So at least for the people who've heard the message, we're making an impact and people are recording it. I'm going to ask Teresa, I think that you're both in a hospital administration position, leading a hospital. You're an anesthesiologist. You have a different perspective on this. What do you think are the barriers? This is really a change management project as much as anything.
Absolutely. I think there are many barriers. One is that disconnect between what we do in the office and its impact down the line to the patients and their families and even children. If we really think about it and start connecting the dots, it's our prescription pad. Obviously, everything's electronic now, but it's our prescription pad that introduces people to opioids. And so, yes, with the opioid crisis, a lot of the opioids that are literally killing people are, they're illegal opioids, they're manufactured synthetic fentanyl, et cetera. However, that's not the start of the exposure to opioids. It really is with physicians and dentists and podiatrists and our prescriptions. So if we connect the dots, that the mismatch between what we prescribe and what patients use, that is the start to the opioid crisis. And it starts with, how do 12-year-olds get opioids? Okay, they get it from someone's medicine cabinets or a family or friend, and it is from our prescriptions. We are doing that. We have to connect the dots between what we prescribed and how those medications are used. So that's what I would encourage as far as emphasizing the need for change, as well as understanding that we don't have to fear that we're mistreating people if we don't prescribe opioids. We have information, we have data that we can manage pain well with minimal opioids, and opioids being used as a rescue medication and not as the first line. And to be honest with you, that's how many of the patients are using the medications anyway. We just need to align things better with how patients are using it. And last but not least, I think that the change can come with understanding that we all have a role to positively impact what's going on with our patients as well as what's going on in the community. So, I think that these are not large barriers, and the fact that there's been improvement in the prescribing practices, as hard as they are to change, it does look like we're making some inroads. And so I have to give credit to the ACHQC regarding paying attention, listening, and participating. I mean, I think that that's awesome. More to come.
Thanks, Teresa. I mean, that's a great segue to Mike and Ben's leadership of, sort of realizing this is a big issue and sort of giving us the baton to run with it and try to impact change. There's a lot of chat about, is the surgeon is the problem, or are the patients the problem? I think Teresa suggested that we physicians are the barriers to this. So I'm going to pick on Jeremy just because I see his face pop on, and Todd is a little late. He told me he was going to come late, but Jeremy, I think you prescribe somewhere like 3 or 5 tablets for your procedures. And can you tell us about how you arrived at that? Have you been doing it for your entire career, or did you start at a higher number and incrementally work your way down? And how are your patients doing with that?
Yeah, so this has definitely been an ongoing project for a few years now. I think I first really got turned on to this being an issue. It was actually your last hernia course you did in Orlando, Mike. And I believe it was Jake Greenberg presented one of the initial papers from Dartmouth on the actual number of opioids that patients take after common procedures. And kind of a light bulb went off at that point, and realizing that, all through residency and everything else, you just kind of continue, you do 30 and you just done 30. Nobody tells you why, nobody tells you, why you should be doing 30. Everybody just gets 30 for whatever procedure it might be. And no one ever questioned it. So I kind of went home immediately after that meeting and started prescribing 10, 12, 15 pills for, the inguinals, umbilicals, gallbladders, things like that, and had no issues whatsoever. Then that was really kind of go along with a lot of the ERAS stuff we were already working on here. And really just realized that we could start going lower and lower, started talking to patients more about it. It wasn't too long after that you got involved and really formed the task force here. The work out of Michigan showing how many pills patients were taking. We started looking at our own data. All of it kind of snowballed into building our own protocol for that. So for us, typically a lap inguinal is going to go home with 5 tramadol. And the vast majority of them do really well. Looking at our own data, about 60% take 0. And almost everyone else takes 1 or 2 tablets. And then just a fairly small handful take any more than that prescribed 5 to 8 pills. So that's kind of been a process over about 4 years where we really transformed how we're doing this. Still, like Tony mentioned, there's a lot of still hiccups here in getting the residents and fellows trained on what this is, especially, doses. Nobody seems to know what tramadol is. We actually use that a fair amount. So still those little roadblocks to get out of the way every now and then, but I think we've had a tremendous progress in our practice.
Jeremy, can you tell us how looking at the QC data a year ago changed your practice, or did it looking at your individual data in South Carolina?
I think we dropped it just a little bit further after that. We were already, for the most part, under 10 for almost all of these procedures anyway. So it wasn't a huge shift, but I think it was a renewed focus on the patient education piece. as Arielle mentioned. So I think that's really been key for us, is really spending time with the patient on that. And we usually do that in the office, and then we do it in the pre-op area right before surgery, and then reinforce it again with the family when you're talking to them post-op.
That's great. So I'll sort of stir the pot a little bit, and then I welcome sort of critique, feedback, and dialogue. So, like Jeremy, 4 or 5 years ago, I was prescribing 20 tablets, and then we went down to 12 tablets, and saw that there was some decent traction, and patients weren't calling back for refill. And what we noticed, we wrote up a paper right around the same time that Dartmouth wrote theirs, and we observed that something like 90% of our patients were using less than 3 tablets. And that really forced me to look at my own data. And, I was in private practice working with a single PA, and we're able to say, all right, let's take it down to 6 tablets and see what happens. And the patients did not call back for a refill ever. There was a rare patient that had a history of opioid use, or patients with chronic pain, that we would work with their pain management specialist and sometimes give more to. But for the most part, more than 90% of our patients did fine with 6. And for the first year of the opioid task force, that's what the data that we put in for, a few hundred patients. What we saw was that something like 70% of our patients were taking none, and the majority of our patients weren't even filling the prescription. And so based on the QC data, we went down to 3 right at the time of the summit, because we all had our own individual data within our task force. And I do think that one of the most powerful things as the task force we've done is provide surgeons their individual data, so they can see what their patients are doing. And all of us were over prescribing. And sort of, I don't know what the right word to say for it, but when COVID happened, we were still operating, and we started going to electronic prescribing, and I felt like I didn't want to write paper prescriptions. We're operating in an ambulatory center. I was afraid to exchange pens with patients. And so I stopped prescribing any opioids. Just told patients, take Tylenol and Motrin, call us tomorrow morning if you need something. And so the last 300 or so cases that we've done, we haven't prescribed opioids, except for a rare patient that asks for them in the recovery room. And that's going to be much less than 5%. And so I've done close to 60 Schuldeis no mesh hernia repairs in that time period. I think that's the most painful hernia operation any of us can do. And those patients go home with Tylenol and Motrin. So I'm going to stir the pot and challenge us all that I think all of us have to do this incrementally and see our own data, but I do think we can get to 0.
So, Mickey, so first of all, congratulations, guys. I mean, when I think about the impact of the QC, I just cannot. I have a bit more of a 30,000-foot view of spending the last decade trying to get people to change their practice, and I think that quality improvement is messy. To Tony's point, there's not a one-liner, and this is a lifetime of work in the real world and in medicine and with surgery. It's just a Herculean effort. And so when I think about kind of the biggest challenges that you all face, kind of beyond the people who are kind of tuned in here, and as we expand this to go more and more in life, but particularly in surgery, when you really kind of think about what we do, it's a very, very low threshold to get a surgeon to try something new or do something different. And there's countless examples of that throughout surgery, whether it's trying a new mesh, trying a new technique, trying a new device, whatever. That stuff, we are naturally kind of curious, confident, don't always know the consequences, but we'll do that. But what I think your biggest struggle here And I certainly am a kind of a poster child, because I used to give 50 oxycodones for every inguinal hernia, for every lap inguinal hernia, no matter what. And now I do 10, like you guys suggested. Maybe we'll go lower. But what I think what you're really trying to do here, when you think about kind of change management, is you're trying to get someone to stop doing something that they've been doing. And I think that is kind of, for the surgeon's perspective, right? That's the psychological challenge, that when you think about what your elevator pitch is, when you think about your story is um, you're not actually telling us to do something new. You're telling us to stop doing something that we've been doing. And so to me, when I look at your data, what is most compelling and what is the lead point is, um, nobody's taking the pills that we're prescribing. Your patients aren't taking them. You're just giving out stuff that you don't need to give out. So we don't prescribe Lyrica for every patient. We don't prescribe, all these other medicines. So as physicians, I think most of us inherently do not want to do something that the patients don't need. But that kind of psychological aspect, and when I see this, particularly with Rana, what you presented of, look, these people aren't taking it. And I can just tell you I mean, you really showed it so nicely in pictures today, but what completely changed my whole perspective was just the way our practice works is, we hand out those PRO forms. The patients click the box and then they hand them to us when we come into clinic, and we put them in a little thing for the research residents to input. So like as a surgeon, I actually see it. And I'll never forget, I know Luciano, I think, is on the call, who was our research fellow at the time. And I kept saying, I'm like, how can this be? Like, people are taking 4 oxycodones after a TAR. Like, I don't understand this. And so until I saw it, and I was like, nobody's taking the medicine that we're prescribing. Like, why am I doing this? To me, that was kind of my aha moment. And now I mean, I haven't gone to 0, but I'll go to whatever level, you know, we decide as a group. I just play by the rules. I've gone to 10, but I think that I think that is number one. That, remember, you're trying to get people to stop. And the other thing that I think that in you guys messaging that is, I think, significantly better and a little bit more appetizing for kind of people listening to it is, particularly from the summit until now, which I think is a much more effective messaging, is that you focused on, instead of saying we are taking away narcotics, instead we are adding multimodal pain management and all these other things, and we're just using that as a rescue. Because when it starts off with opioid reduction, again, it gives me that inherent, I'm taking away something that my patients need, versus, and now I do what you said. I mean, it totally works. I say what you said. I go out at the end, I say, hey, look, we're going to give you the script. Most people don't need it. Don't take it if you don't need it. Stick with ice, alternate Motrin and Advil, and it is impactful. But I think it's getting that buy-in and kind of just, the psychology and the business aspect of change management is actually now where you're at, which is I think another thing to think about, of kind of querying surgeons and understanding, which is probably a deep rabbit hole, why we do the things that we do. But I just want to say, I think the changes you guys have made so far is just absolutely phenomenal and super exciting for me.
Thanks, Mike. I think you hit the nail on the head. This is as much a change management project as a quality improvement project. And so I want to challenge the audience, those that are on, to come up with, not solutions, but ask us questions or make suggestions of where you see an opportunity to affect change better. We have a committee of 16 people. We have 24 or more people on the call. The more opinions and points of view we get, the more effective we are going to be at affecting change. So I'm going to let people think about it for a second. I want to pick on Todd Harris, who joined us. He went through a similar experience that Jeremy and myself, I did. We want to hear from him. What does it take to change? What did it take to change your practice, Todd?
Yeah, I'm sorry I got on so late. I was just wrapping up things here on the West Coast. I'm trying to get my feet back under me. But yeah, at that summit 2.5 years ago in Chicago, I looked at the screen and saw your data, Mickey, and I knew I had been writing 30 pills since residency. And so when I came home, one of the things Mike Rosen said at the beginning of that summit was like, hey, try to at least do one thing when you get home. And when I got home, I said, that's the easiest thing for me to do. I still can't do a robotic tar, but I can write 20 pills instead of 30. So that was an easy change for me. And I expected, patients calling in the middle of the night, and I'm in private practice, so I didn't want that. But I found really no changes in my patients. And then a year ago, I saw, people again, the challenge was to write for 10, and I did that again, expecting to get calls on the weekends, and it just never happened. And anecdotally, I've actually gotten a lot. Maybe you guys have talked about this before I got on the call, but there's been even less patients asking for refills. And when I look back on it, if a patient took 30 opiates over the course of 4 or 5 days, like, no wonder he wanted more opiates. So, looking back, and those aren't patients who are becoming addicts. It's just inherent. That's just sort of subconscious. If they took that many, they're going to want more. So yeah, I think, for me, getting down to 10 has been great. I will say, I think I looked at the slides from Rana and Arielle over the weekend, and I think Arielle showed us where we can get some of that multimodal information to provide to patients. And I did make a fairly robust change in my protocols, and I came up with a multimodal pain management protocol that I now hand out to patients. And I took a lot of information off that, the Michigan Open and our other note card. But so I did sort of preemptively educate the patients on multimodal. But yeah, I think, for me, again, it was, I walked from 20 or from 30 to 20 to 10. And I, again, not having taken part in the whole call, I'd say the one thing to challenge the surgeons out there is, like we talked about back in December with David was talking about heavyweight versus midweight mesh. And at the end, we're all like, do you trust your data? And if you trust your data, then make a change. And I can tell you unequivocally that this data is real. To those high prescribing surgeons that might still be on the call, the data is real. The patients are not using opiates. And so I would just summarize by saying, trust the data and go as low as you can.
Todd, how many phone calls have you gotten in the last year for someone asking for opioid refills or more opioids than you prescribe?
It depends on the number. I don't know. Maybe I did 250 cases or 300 something, and I don't know. Maybe I got 1 or 2 calls. And I'll be honest, one of them was like a patient's wife was just worried that he was going to run out, and we didn't do anything. We didn't write any more, and when he came back, he was happy. So yeah, I'm talking like 1 or 2 out of hundreds and hundreds and hundreds of cases.
I think the patient call thing, Randy Jancek kind of put a thing up here, which I think is so important. I think it's just kind of one of those things that we as surgeons just make up, because you have one patient who calls you that bogs you down. I do think with the changes in being able to call in narcotic prescriptions now, that's really, really gotten rid of a lot of those issues. And so I think that's just something that you have to tackle with your data, which is people aren't taking this stuff. Like, people are not taking what you are prescribing, period. Like, that is what you've shown. So why would people call for things they're not taking? It just doesn't line up with the facts anymore. I've been guilty saying that myself too, but when you look at that, people aren't taking this stuff, maybe because they're afraid of it, whatever, but not even anything to do with what we're doing. Just the lay press is really pushing how bad this is. But at the end of the day, these are medicines the patients are not taking.
Teresa, I saw you waving. Do you have more? No. Okay.
No, I was adjusting my camera. No, but I think the conversation here is spot on, and again, focusing on what the patients are actually doing, and it really ranges. I mean, patients are patients. Sometimes people tuck them away, and 3 years later they have an injury of some other type, and then they're using them there. They'll have another patient who will use it for sleep occasionally, or they'll have a friend or family member that has a dental procedure and is having pain, and then they'll give 1 or 2 tablets away. So it's not a really malicious thing that goes on. Patients, if they fill the prescription and they don't take it, they just tuck them away, most of them. And then you have other patients who throw them away and just don't tell us about them.
And I think Clayton brings up a great point, Mickey, in the chat. He said that patients that call, the ones that call are probably going to be ones who are going to call no matter what. And I know that's been a discussion point in our task force is what are those risk factors? That's kind of the next step Clayton had mentioned he wanted to look at as well. Is what are those risk factors for the people who are going to call and who are not in that category of not consuming? Because the vast majority are in that low consumption category, but there's certainly risk factors for those who are going to be the ones that call. And like Mike said, those are the ones that stand out in our mind, but the vast majority are not in that category.
Yeah, and I think those are a couple of points that were on our sort of next projects for the task force. Is one is to really nail down the data, make sure it's accurate, make sure we pick up all the patients who were prescribed no opioids or didn't take any, but then also stratify the low, medium, and high and see what the risk factors are and if there are any. And hopefully we will have that data for the summit in March. We do have a meeting next Monday to try to get that level of detail. The other one, Mike, is I think that, at least from my perspective, one of the barriers are we can show what the QC data is as a whole, but all of us feel like, our patients are a little different, or we do something a little differently. And, before the last QC summit, we were able to get surgeon level data for those of us in the opioid task force. And I know Jeremy and Rebecca, I see her on the phone, are working on some sort of real-time reporting for each surgeon. And I think when we have those capabilities and we can really get good, accurate reporting for each individual person, what their patients are using or not using, then I think we're going to make a much bigger leap. So that's my hope we can get to that this year.
So one thing, and I think, in your messaging, particularly at the summit, I would say, and just to reinforce this for people who watch this, I think that kind of gets to some of the, the way people run the QC within their own practice. So I think that there are kind of, you can think about it, multiple levels of kind of QC engagement, from putting in the preoperative and operative details to the postoperative follow-up, to PROs being done preoperatively, postoperatively, and at long-term follow-ups. And I think that, to get the most out of the QC, it is to do those PROs. And I think that, just to add on, we're also looking at a way to kind of feedback PRO data in a way that surgeons can kind of have a little bit more of a real-time, meaningful use of that data. But I mean, just my own story, as I said, when I saw my own patients clicking, "We're not using this," and I was like, "Wait a second, how many pills did you take? Are you sure you clicked this right? Like, do you understand what I'm asking you?" And so I think that is just, and I think it will grow your data source as well, is just to get people to use those, as Arielle showed, those PRO forms that allow you to say how much people took, because we're one of the few groups that actually have how much you prescribed and how much you took, which is hugely important when you really kind of try and make practice changes, I think.
I see quite a few people who've been listening in. Any questions for any of the members of the panel, any of the speakers?
Hey, Mickey, this is David Carpata. I have a question. So I have actually two questions. So, first off, congratulations to the task force, because this is really awesome work and it's exciting to hear this discussion. My first question is for people who are not prescribing any opioids, is there power of prescription, and do you prescribe the actual NSAIDs or Tylenol for them, just so that they actually have a physical script of something? And my second question is for people who do the 10 tablets. If a patient calls up and wants a refill, you've clearly identified an outlier based on your data. Like, this is somebody who's outside of the normal pain pattern or expectation. So do you treat that patient differently? Do you see them in clinic first before you give them refills, or you just give them a refill and say, let's see how you do in a few weeks?
Dave, I'll take a quick crack at that. I'm going to answer your second question first. We certainly look at patients who call for a refill or call for opioids as an outlier. And I'll tell you, you're an expert in chronic pain. And the last patient that asked for more opioids after a full prescription of oxycodone asked for Dilaudid 2 days later. And I examined him, and it was clear that I entrapped a nerve, and took him back to the operating room 2 days post-op. And I entrapped a nerve in the external oblique closure, and his pain went away. So I think there is something to be learned about these outliers, whether they have a pre-existing condition that makes them an outlier or a surgical complication. So I do think we need to take a look at them. But I'd love to get other people's opinion on that. I will tell you that we do not prescribe over-the-counter analgesics. We tell our patients to take a gram of Tylenol and 600 of ibuprofen, depending on their height and weight. And we tell them to take it every 6 hours around the clock when they're awake. And for the rare patient that asks for an opioid prescription, we give it to them in the recovery room. But I've not found that writing a prescription is necessary. I'd love other people's opinion about the outliers, how they treat them.
Yeah, I would agree with Mickey on the outliers. I've not had that personal experience, fortunately, but that's only because I don't do very many opening inguinal hernias to get as many nerves. But sorry, Mickey. But yeah, I think we will often still, more so for the ventral incisional hernias, they'll often get a refill. But looking at our own data, kind of before and after we implemented this prescribing protocol a few years ago, we actually saw, not statistically significant, but we actually saw a decrease in patients who were calling back for refills. And I think just looking at our own data, the patients who took more ended up taking more. So when we prescribed more, they actually tended to take more, and they tended to get higher refills. So we actually had 20% of our patients before implementation of the protocol were getting refills, and only 10% after that. A lot of that's management, a lot of that's our ERAS protocol, a lot of that's setting expectations, a lot of that's probably taking a harder line. I think there's a lot of factors in that. But I do think those patients, you have a decent idea if it's outside of your normal. It's like Mickey said, he had a patient that was clearly outside of his normal, found a complication. You have a pretty good idea. I don't remember the last time an inguinal hernia asked for more medication, but for the ventral incisionals, you kind of know the ones that are expected to take more or legitimately had a really complex operation that legitimately might need more. So I think you can really base that on each individual patient. As far as the prescribing goes, we actually do routinely prescribe the ibuprofen and Tylenol. I don't know for sure if it makes a difference, but it seems to. Again, anecdotally, I've never had a patient call back and ask for refills of ibuprofen before we started doing this. So, our nurses in the office can absolutely tell a difference in how many calls patients make to us since we started doing this. We get a lot fewer calls for refills than we used to. I wish I had a better way to track that, but anecdotally, it's made a huge difference.
I think we have a database that tracks whether you prescribe or recommend these. So we're going to see if they're independent variables.
Hey, Mickey, and group. I'm sorry, I'm joining in late, but I just have one quick question. And again, congratulations. You guys have changed our practice in Seattle significantly. But have you seen a difference in, we all give scripts because we're worried about the patient having to drive far away to pick up a script, but we now have, I guess it's called Impritav or whatever that thing is on your phone where you can e-prescribe. Have you seen, do you use that at all where you don't have to have a physical script anymore. You just basically approve it on your phone. Is that a common practice with surgeons in the QC, or is that something that we can look at? Because I think that factors in for me specifically. If I have a patient lives farther away, I'm more likely to probably maybe give a few extra, which is old practice, I know, but we do now have this other function on our phone where you can just approve it and they don't need a hard script anymore.
Anyone in the group can answer that?
So I think that makes a huge difference. I think that's totally enabling for us to prescribe less because you don't have to worry about the patient driving back in to get a paper script. So yeah, I think it's incredibly helpful.
Anyone else have that tool or have found that their patients are calling for refill since they went down to 10 from a higher number?
I know. So, I mean, I've gone down to 10 and I haven't had anyone call for refills that I've seen in follow-up or anything like that. And most honestly have just anecdotally been using about 1 or 2 tablets. We also in Wisconsin have an electronic ability to prescribe opioids, and you have to review the drug prescription database in order to do so. But you do have that capability to do electronic prescribing, which is really helpful because we are a hub for a lot of referrals from up north. So I think that would definitely impact practice, Rebecca, because then you don't have to give additional opioids just because the patient lives further away. You have that electronic ability if you need to.
Yeah, same thing at the Cleveland Clinic. We had, within the last year, it became possible to electronically prescribe an opioid, and that wasn't always true. It was, you'd have to physically mail them a prescription or they'd have to come pick it up. We don't have, to my knowledge, we don't have the phone app ability, but at least we can do it electronically. That makes a huge difference.
Hey, what do you think our call-in rate? I mean, typically probably Emily deals with those, but I mean, it's got to be incredibly low, don't you think?
For inguinals and umbilicals, like things we talked about today, yeah, I think it's probably incredibly low. It seems like it's usually the ventrals are the ones that most likely we're getting a call about. And I try to always look up, like when someone does call, like what was their risk factor? Like, did they have something that we could have said, okay, yeah, I'm not surprised. And it usually, not always, but usually, it's someone who was on opioids before or had, some history of chronic pain or something like that, where you look back and you go, okay, yeah, you're not totally surprised, which is one of the reasons I wanted to kind of look at the risk factors. Because when you look at things that there's tons of opioid data being published all the time. And the things that the QC can specifically do are one of the things you mentioned, which was you have the combination of prescribed and consumed. And then the other thing is, the risk factors, the opioid risk factors that we put in the preoperative comorbidities. And so looking at those types of things, and if those types of things can predict, who's going to be more likely to call in for a refill. And on the flip side of that, people who, what are the risk factors or what are the demographics of someone that doesn't take any? And so if you were someone who maybe was considering starting prescribing no opioids, maybe there's a group of patients who, is most likely to be fine with no opioids. So those defining the people most likely to not require any and the people that are most likely to require more is what is the next step. And then, the one thing I think that we're missing that I think this discussion has made clear is that we don't have the ability to track the refills. When we go to the 30-day follow-up, it feels like there should be a button there and there's not.
That's a good segue, Clayton. I mean, I think there's it's feedback that we've actually we're looking at, and so you know, it's certainly we can we can do quality improvement in the way we collect the data and present the information. So this is an ongoing project, and obviously a long-term project. So I really want to thank everyone for their participation, everyone for showing up. Ben's not here; he's busy watching the Ohio State and the national championship game. So we'll give him a shout out. And it's Mike and Ben's leadership to kind of make this a priority for the QC in terms of data collection, in terms of the incentive for surgeons to collecting the data, and then to all of you who spoke today. So I think with that, we're probably going to need to wrap things up, Mike, and do something in March.
So listen, first of all, Mickey and the whole crew, congratulations. Like I said before, I think what you guys are doing is incredibly impactful, and the glass is way more than half full. So congratulations, take your wins. That is phenomenal. Great discussion, great presentations tonight. And again, great work. A couple quick announcements just for everybody before everybody gets off. Any residents or fellows that are on the call, we do have a resident and fellow committee. You can sign up on the website. There's a little page for the residents and fellows. I know a lot of folks are using this like Journal Club, and we would certainly encourage you to do that locally. This will be a monthly session. If there's any topics anybody's interested in, please just email me directly. We're always looking for new and interesting things. This can be kind of hot QI topics, research that's just been done versus published work. So that's all out there and available. I will just say our next one of these will be February 8th, 8 o'clock. And it will be on fixation versus no fixation for retromuscular hernia repair. Ben Paulus has done a lot of kind of sophisticated work based on the QC data. And I know that's kind of a near and dear topic and controversial to everybody. So we'll have a great kind of point and counterpoint on that as well. So again, thanks everybody. Great session. And go Alabama. SEC, baby. I'm a Southern boy at heart. All right.
Thank you.
Bye-bye.
Thank you, everybody.
Thank you.
Thanks.